Okay, so we've heard a little bit about the challenges. And as someone who is not very familiar with this sector, I was a little dispirited too. And so, as I indicated at the beginning, what we thought we would do is orient us to the sector and the differences and similarities between the three main divisions that we have. And as I indicated, we would like to base our decisions on best available evidence. And so the purpose of the next section is to hear from three people who are very familiar and perform the research that informs us, to tell us a little bit about what is known, what isn't known, and I think both of those are really important. And along the road, we'll hear some of the challenges of actually getting solid answers to some of the questions that you all have. And so to help us in this process, starting at this end, I have Barbara Silverstein, who I've known many, many years, and we won't say how many for both of our benefits. And Barbara is the senior epidemiologist in Washington Department of Labor and Industries, previously before you retired, correct?
Yes.
So congratulations on your transition.
Thank you.
Now, next to her, we have Dr. Tilak Dutta, who's a scientist at Toronto Rehab Institute. And on the far end here, we have Dr. Mike Frey, who's a senior lecturer in human factors design at Loughborough University in the United Kingdom. And so, welcome from across the pond. And so, I always think it's important in any of our conferences to hear from people from around the world, because sometimes we get a little stuck in what we're doing, and it's sometimes nice to get new ideas or have our ideas supported or whatever. And so I think we have three excellent people here to help us understand where the evidence is and where it isn't. So similarly to the first section, we had an original no PowerPoint zone, but we've had a little bit of creep. And so I think we're up to one slide each, but that's good. And so in the same way that we're not having presentations per se, but I've asked each one of the participants to kind of review a little bit about what they see as the evidence from their perspective and from their interests. And then once that we've done that, we'll move into a little bit of dialogue, and then we'll ask you to join us on that one. And so, who would want to open that? I think we decided that, didn't we? Yeah, I'm glad you know what we're doing.
I'm happy to start.
Do you want to do it from your chair, perhaps?
Oh, sure. Yeah, sure. So, just to set the stage for this discussion, I actually thought Sue Vanderbeek did an excellent job of highlighting kind of the story as we understand it. The biggest challenge when you think about older adults living at home, what are the challenges they face? How do we keep them at home as long as possible? Our team tries to figure out what are the biggest challenges and how we can solve those challenges. So what I'm going to present here is kind of my top five pieces of evidence that inform the work that we do and that make up the basis for the work that we do. So I guess, can we throw on that presentation? The first one really is that healthcare workers, if you're a young person or you know a young person who's looking for a career and you want to make sure they don't get injured, they should be a miner. They should go into the mining industry, because there are half as many injuries among that industry as there are in healthcare workers. So, I might just need to stand up because I can't actually read what's coming up. Yeah, so that's half the rate of injuries in healthcare. Sorry. There we go. Second thing, the risk of injury increases over time. Some of us call this the cumulative load idea. So just performing one lift or performing the same lift 5 times, there's a big difference in injury risk. So we know that this idea that injury risk is building over time, potentially over your career, over weeks and months and years as you perform these activities. There's this idea that the more you do, the higher risk you are of an injury. And so there's implications for that for lift teams, trying to control risk by getting a small group of people to do some of these activities, some of the patient lifting activities that we're talking about. It doesn't really, ethically, it might be a problem because you see that you're concentrating risk on a small number of people. You may see less injuries, but you're increasing the risk for that group tremendously.
So I'm just wondering if the mic, can everyone hear?
Sorry, am I not talking into the...
mic doesn't sound so strong.
Sorry, I'll speak closer to the mic. Thanks, Catherine. We know that tissues of the spine can support about 750 pounds. This work that was done based on cadaver studies way back many years ago, where cadaver spines were crushed and people measured how much compressive force these tissues could support. Sounds like a huge amount of load, actually. Why is it that we see injuries when we're doing these activities? Well, it has to do with the way the body supports these loads. And people like Bill Maris have shown that even if you have two people performing manual lifting activities where you're lifting 200-pound people, you exceed these limits in the body. And so you're at risk of injury. You're at high risk of injury performing any manual lifting activities, lifting someone out of a bed into a wheelchair, those sorts of things. And typically the limit that we think is sort of safe is around 35 pounds. You really shouldn't be manually lifting more than about 35 pounds if you want to avoid building up damage over the long period of time. Patient lifts, so we know that manual lifting is dangerous, so we need to use equipment to lift and move people. Patient lifts can reduce the risk of injury, but they're not a perfect solution. Pushing, pulling, turning these lifts themselves is, Bill Maris again showed, as well as our team showed, that these activities can lead to injuries. So we've developed all these tools, but not all of the tools work as well as we think they should. Particularly in the home environment, when you have carpeting and you're using a floor lift, the friction involved in moving and maneuvering people around those locations makes it particularly risky. And so it's really thinking about when we give people tools, finding ways to evaluate those tools is a big challenge, and what our lab tries to do is find ways of measuring things in the field. It's a big gap I think we can talk more about in research in the home care field. We don't really know what's happening out in the field, and the CRE-MSD, in fact, funded a small study that Emily King, one of our PhD students, is leading to look at measuring biomechanics of home care activities in the field. And so hopefully we'll know more soon in that respect. The other thing with lifts is getting slings under people is dangerous. If you have a 200-pound person or heavier, rolling them on a bed itself, getting that sling under them ends up being a challenge. And again, home care workers are at high risk of injury, and I think we've already had the discussion on this, where instead of two people and an overhead lift in the room, you have one person, probably no equipment, limited training. Maybe you're getting help from a family member who has no training in a cluttered, dirty environment. So it's a big challenge, and this population, personal support workers at least, are people who are unlikely to complain about the problems that they're facing, or to complain and say that they are under unsafe work conditions. So it's a tough group to really understand what the biggest problems are sometimes. That's it.
Thanks very much. Thanks for the introduction, and thanks very much for the opportunity to come and speak. I thought I'd just start off with two personal comments other than my thank you. The first thing is I will be running classes over lunchtime about how to pronounce Luga Baruga. go all around the world, nobody gets it. The only people who know how to pronounce Loughborough are the people who live or work or who have trained in Loughborough. The second point is, I've been really disappointed for about 25 years now. But we keep on keeping on. I attribute my career path to playing golf. It is an iterative process. I start off in a field, somebody roughly points me in the direction of my target, I take a swish at the ball, sometimes it goes closer to the hole, sometimes it doesn't. I then go and position myself behind the ball and I need to have another hit. And I've been doing other hits for many, many years now. The focus of my little section here is that I'm going to take a look at this idea of training. How do we deliver training? Why do we deliver training? What is the process and what is the evidence behind it? And I'm going to be disappointed because there's been a number of reviews, formerly Hignett's book in 2003 that looked at 300 intervention strategies that just shows training in isolation doesn't work. It's the worst possible solution for improving workplace behaviour. Whereas if you add interventions, if you add equipment, if you add policy, if you add process, if you add changes within the workplace, and particularly if you deliver a better level of commitment, then you do end up with changes. So I would like to discuss training and education as a supporting mechanism for change within the workplace rather than the primary cause of how it works. So the process and the activity then is about, training and education is a much greater process than just teaching people how to use a hoist or to do a particular moving and handling method. So we do need to appreciate that this education package, this process, is a wider based activity. Now the difficulty with the evidence, and we could talk long and hard about why these high-based academic reviews don't show a difference, is that we're teaching people at one level and yet we're measuring the outcomes purely on whether it affects the number of musculoskeletal disorders we have in the organisation. And that there are so many stages between you training somebody and that illness or injury. Scientifically, it is almost impossible to prove that link. They are exposed to far too many other confounding factors to put that link together. So we maybe just need to think about what are we measuring and what are we educating them in and how do we measure it. So this support, bearing in mind that the whole process of training and education is to support the behavioural change, improve the performance of your organisation and or your staff, we do need to consider that this level of education needs to be across the levels. So it is about people being able to use the equipment to deliver the transfers and be able to deliver that activity. But it is also about your organisation. It is about your CEO and what do they understand about their roles and responsibilities are. It is about the managers of your services, the managers of your wards, the managers of your home care delivery processes. What are their responsibilities? What should they be doing? How could they support the process? It's about workplace supervisors. It's about having somebody on the ward working in the teams who can say, that's not quite right, try this method. If that process doesn't work, then we have other things in our armoury that might make it happen. So there are, that we do need to consider this education process as a wider process. And I would add into that equation the idea of the expert. I'm sure if I asked for a hands up, how many of your organisations buy in help? So you buy in someone who's going to come and do your training or do some risk assessments or educate your staff? Number of hands flicking up around the room. You also need to ask the question, where have they got their education from? Who says they're an expert? They do. It says so on their CV. You've bought them because they told you they were an expert. So internationally, there are many different approaches that different countries have taken to look at that process. Very close to you here, you have an organisation called the ASPHP. They run a competency-based, a 2-level competency assessment program. You can be a certified professional, or you can be a certified practitioner. And it's an externally validated program. It's a thorough certification process. Over in the UK, we love a piece of paper. My, do we like pieces of paper. The bigger the document, the better. The more rules, the more regulations, we just can't get enough of it. We did an international survey, and the pile of British documentation was this big, and the pile of the rest of Europe was this big. We're good at documentation. We're good at that process. So we educate our people through our universities, through postgraduate programs, primarily leading to ergonomics qualifications. But there needs to be something that justifies their knowledge and improves their knowledge and improves their ability to deliver safe systems. We'll come back to this in the close-up session about safe systems of work. There have been some interesting discussions already about that. And I thought just to bear that educational process in mind, I thought I'd just add a couple of experiences that I've come across over my years in the process. The first thing is, there is a question, I think, a really important question, and some of you have identified it in the opening session today, is the important thing competence, or is the important thing compliance? Or is it both? Because many of our training systems and sessions train people in skills, decision-making, choices, processes, activity, but they then go away and do something completely different to what we've planned. So you can make them the best skilled trainer and handler of people in the world, but if you don't deliver the right environment and equipment, then they won't comply with what you have predicted. And so there is a mix and match, and much of my research has looked at both of those questions, and it is impossible to not have them both in your system. The second thing is, I opened up with this idea that the reduction of MSD is really difficult. The question is then, what are we going to measure? How are we going to prove that our training methods are improving what our staff do and what our organisations do? So we might need to think about knowledge and skills and decision-making processes, even compliance with a written plan for what should happen. Maybe that's the measure that we need to do. I would agree with Tilak's slide on this idea that exposure actually might be the best measure we've got. So if we can reduce exposure, then our staff will be healthier, our patients and our service will also be better. And I think the final thing that I'd like to add just before I hand over is many of the processes that we've seen in the UK and across Europe and in areas where our legislative change happened 20 years ago now, people are bored with safe patient handling training. They've had it. They have had it again and again and again. And unfortunately, the first 10 years, they had a different course every year they had their update, which was a bit of a challenge. But our standard practice is standard practice now and has been for probably 5 or 8 years. We know how to assist somebody from sitting to standing, standing to sitting, horizontal transfers, the whole gamut. There's a really big consensus in the methods and activities. But we need to make it a patient issue. We need to make it about care. We need to make it about improved care delivery. And so I came across these two. I'm doing some work on a health and safety project funded by a UK regulator. And we've come across in some of our qualitative judgments and investigations about two philosophies that carers use to keep themselves safe or deliver best practice. And the first one is my own health. Well, you can go to all of your organisations, all of your carers will know somebody who has been retired through ill health because of patient handling injuries. And that hasn't changed the way they do the activity. They still go on and they still do it. They still put themselves at risk. We all still drive above the speed limit, don't we?
Yes.
But we know what the rules are, and we know if we hit something doing too many MPH, it's going to really hurt. But we still do it. Risk is an interesting process. So that challenge, leading them with the injury thing, isn't the answer. But this point came with a healthcare worker who was part of one of our surveys, and they came up with this statement, and I know I've heard it many, many times before, that in terms of delivering care in any organisation, the judgment that they made for themselves was, I wouldn't do anything that I wouldn't do to my own mother. Now, if you don't like your mother, maybe that's not quite the truth. But isn't that an interesting point, that in them understanding, them rationalising, how do they make this thing better, they make a judgment that this is about personal care. This is about improving comfort, dignity, respect, reduction of patient skin tears and pressure area care and all of those other things that go with it. And for me, in our long history within the UK, I think our big limitation was that we didn't make it a patient handling issue fast enough. It was a health and safety regulatory process for many, many months and many, many years. And only now are we trying to really rebuild this process by making it about the quality of care. Thanks very much.
I've known Richard for quite some time, and am really quite pleased that he's taking on this issue of having this kind of conference. In the interests of full disclosure, I have to say that many years ago, I was injured as a nurse in the city hospital, where two of us were trying to lift a 350-pound patient out of a high bed into a wheelchair. And I ended up underneath the patient. And that basically ended my acute care nursing career. But one of the consequences of that was the workers' compensation system in this case, and I went back to the university because I already had degrees in nursing, but I went back to the University of Michigan and went into occupational health and ergonomics. And I think, so I have this passion for trying to reduce injuries to healthcare workers, and I've had that all along. In Washington State, where I just recently retired, I'm happy to say, I was the head of the Safety and Health Assessment Research Program, and we did a number of studies in over the years, in nursing homes, 35 nursing homes, hospitals, and so on. We did not do anything in home health care. And I actually think that home health care is probably much more dangerous than working in the ICU or in a medical ward or a surgical ward in a hospital. How many of you would agree with that statement? Yeah, okay, good. Well, so anyhow, we did a series of studies in different healthcare settings over the years, and that ended up eventually in our passing being the first state in the United States to have a law on safe patient handling. And the problem, and this may be completely not relevant to you, but the problem for us, and we didn't realize it at the time, is that the legislation indicated that the Department of Health rather than the Department of Labor and Industries, would be responsible for ensuring that hospitals were doing something, were doing what they were supposed to do. And so the Department of Health pretty much cared much more about patients and about whether there were processes in place for patients and not for the workers. And so turning the regulatory authority over to the Department of Health, they just would, when they'd go to a hospital, they would just click it, yes, they've got this program, without actually looking to see whether anything happened. So that was an error, and I don't know if you have the same kinds of issues, jurisdictional issues between regulatory agencies or not, but that's one to be careful about. We really weren't. Anyway, so we've done, we implemented the legislation, and we've been following it ever since. This was in 2006. But it was only for acute care hospitals and not for nursing homes or home health care. So that's a problem in terms of where things are going. I think in the United States as well as in Canada, in terms of a much older population distribution. That's true, right? In Canada as well. Okay, so fine. Okay, so you have, I think, everybody has my handout, so I'm not going to go through them, because Richard said I only get to use one slide, and here it is. Okay, and so one of the things that I think is really important for all of us to look at in healthcare is what the model that Pascal Carrion from the University of Wisconsin developed years ago on work system balance. And the basic premise here is really looking at where there are disconnects, where the lines would be cut because there's not a connection between these, that you have an increased risk of injury. And so it's really important that as we're looking at our safe patient handling programs, wherever they may be, that we really look at the relationship between the technology that we're using, the way the work is organized, and the way the work is organized not just for you as let's say a nurse on a ward, but the organization as a whole, where you've got these feedback loops to upper management, to direct caregivers, and to custodial staff, who also have an important role to play in nursing homes and in hospitals. And increasingly, and this is probably true in Canada, and I'd like to know if I'm wrong, but that with an older population in the US, the population is getting older by and large, that home health care is really going to be the wave of the future, and not hospitals and nursing homes in terms of where the growth in jobs is going to be. Is that true here too? Yeah, okay. So, when you're in an institution, you have some sort of level of control, theoretically. When you're doing home health care and you're going, to people's houses and so on, you really do not have that same level of institutional support to be able to get the things that are needed. At least in the U.S. it's true. Maybe in Canada it's different. It's not different. Okay, so I think that's really a challenge that we really need to look at and come up with some creative ways, and then share those ideas if it turns out to be successful. Okay, so I wanted to just say another thing about, at least in Washington State, that we were the first state to have legislation on safe patient handling in the United States. And the reason that happened is because we had 4 nurses in the House of Representatives in Washington State and 4 nurses in the Senate. And those nurses browbeat their, as nurses can, being a nurse, that it was unanimous that there'd be safe patient handling legislation in the state of Washington. So I'd just like to say that I think that that's important to use legislative, talk to legislators if there are programs that you think really need to be implemented in terms of safe patient handling that haven't been, and particularly going further out into home health care, which is, we've heard already today, is really important. So my one slide here, I mean, basically, the thing that we look for is breaks in this system in terms of a balanced system. And the kinds of things that we see happening are errors, absence, and injury to workers, primarily overexertion injuries, and burnout. How about you? Do you see the same things? I mean, I think, yeah? Okay, good. So I think I have a series of statistics, and you have that information, I think, already, so I'm not gonna go through that. But I think that the idea is that where we can have the biggest impact, whether it's in home health care or in hospitals or nursing homes, is really the design of the work system. And really looking at the design and whether or not it's really being implemented and expanded upon as need be. And I've given, since you have the handout, so I've given you some examples on how this can be done. And I have a question for you, because I'm ignorant about your history in Ontario, and this is on one of the slides, and it's really in 2004, 2005, you got special grants, right, for lifts and so on and so forth. And this was to focus on nursing home, which is really important. But you were also awarded, there were awards up to $1 million, I guess, for the effectiveness study. And I don't know what happened with that study. Can you tell me?
I think it was reported
good.
at one of the Florida, I think it was Mickey
Oh, yeah.
Kerr, it was
Okay.
Cam Mustard,
Yeah.
did report some results from that. I think
Okay.
unfortunately the results were that it was found to not show an effect. The criticism of the study, as far as I remember, was that they measured too soon after. If I heard someone in the audience, feel free to jump in if there's other comments on that. But that's my
Okay, okay.
memory.
Anybody else have ideas about that?
I think the other criticism is also that it wasn't a multifaceted,
Okay.
implementation. It was
Yeah.
you put lifts in, but just because you put lifts in doesn't mean that people use them. We speed. We know what we should be doing. I'd love to touch on some of the topics you brought up. The cultural. I think both of you brought up interesting points about the cultural challenge. And someone in the earlier panel was talking about how healthcare workers have a culture of sacrificing their own health for their clients or patients. And that's really unfortunate, and we have to find a way to shift that, right? I think it's really telling that, so Audrey Nelson, who spearheaded a lot of the safe patient handling work in the States, she tried to get these programs funded for a long time with different monikers, and it wasn't funded until she started putting it in that phrasing, safe patient handling. It's about the patient. Right. Previously it was about staff safety. But I think we're now far enough down the road that we have to come back and say, no, look, the whole point is it's a balance of the patient's needs with the healthcare workers' needs. And if you're talking about the home care environment, how do you make that a safe workplace while also providing the client what they need?
Good, good. Anybody else? Any other ideas here? Okay. I want you to, since you have this, I gave you the punchline for why I had bamboo on every picture, right? And it really is that you can't kill bamboo. And the same should be true with safe patient handling programs. And I have on the last page, or the last slide, is really looking at who needs to be at the party. And in order to make this really not just a name, but actually a functioning action and way of doing business. And I think that one of the things in Washington that we hadn't done when we implemented our safe patient handling legislation is we hadn't considered designers. And quite frankly, designers of hospitals and nursing homes, if they are educated in sort of the needs for safe patient handling, they can come up with absolutely brilliant ideas that are not necessarily high cost, that can be used to really facilitate safe patient handling as a way of doing business. So, I think that's all I have to say.
Thank you, Barbara. I heard a number of things here, and those were fairly large issues in terms of training, supporting other interventions, in terms of work systems. And I really liked your idea of the bamboo so that it doesn't not happen. And so, yep. And so what I'd like to do is see whether the audience has any questions for our research panel here that come out of their own experiences or things that they've heard here today.
Yeah, maybe just a couple of comments. Pictures in our Ministry of Labor. So we get into a lot of nursing homes and other healthcare facilities. And as far as the ceiling lift and other lifts, unfortunately some of that funding almost should have been more for ceiling lifts, because some homes decided just cost-wise not to put them in. But what I found, it's only anecdotally, that the homes that got the ceiling lifts and hospitals have found them, the staff, people have found them really helpful. I don't have stats in terms of injuries, but that whole issue that somebody mentioned in lifts being stored at the back and the time to go get them, and that they're there, they're available, they're charged, and at least anecdotally, really important. Maybe just a quick example of design. I was in an old nursing home, and they were building a new one, and they happened to have a thing on the wall, plan on the wall, and the toilets were all shoved up right against the wall. And I say, why are the toilets against the wall? Like, if people have to get in and assist somebody. I said, well, we're still in the design stage, and I got to see the home, and the toilets didn't cost anything at that time to change it, but if they had built it that way, they would have had a heck of a time. So that design being so crucial.
Very important.
I work in acute care, and I do some of my work in training, and I do provide some acute care as a clinician. I read the literature about lift teams, and I struggle with it, because I understand the thinking. I think, and you please verify this for me, a lift team is somebody who is an expert on a lift. Is that who you'd be in your lift team? But are we not worried about the frequency that they do their job, and that they'll break down, because suddenly now that repetition factor has increased significantly? So I struggle with the research. And any other comments to that?
Yeah, I'll go first. We had this very same discussion last night. You're quite right. There is a concept behind, a philosophy behind the lifting team, and that is that, and I would suggest that if you looked at the evidence, it is very compelling, because the measure is safe patient handling injuries on qualified nursing staff. So if you say your qualified nursing staff will not be doing the safe patient handling activities, and you get this team of people to do them, then your claims go to zero.
For the nurses.
Yeah, no, that's exactly
what about
right.
the
That is
team? Did
exactly the
anyone look
point.
at
So, bearing in mind that this, lots of the discussion earlier on was about cost. So if your accountant or your CEO gets a sniff at that, they're going to start doing the sums. They're going to start looking at those millions of dollars and try and work out how they're going to implement lift teams, just on a finance basis. The piece of evidence that has not been given by the hospitals and the systems that have adopted them is what happens to the lift teams.
Right.
We haven't had a longitudinal study. They might have a shorter career path than an American football professional. They might go in, do one lift and gone. That might be it. We don't know. That we've not had that evidence and that data presented. So on one side, you've got a really compelling argument that this is going to save your organisation a huge amount of claims, and on the other side, we just don't know. and I think you're right. I think your assumption and your interpretation of the evidence is exactly right. And maybe we should just force those locations to stump up the data so we can actually make a formal judgment about it.
The cumulative load on the spine has got to be incredible when that's all they're doing is doing these transfers. I mean, I think that's really a horrible idea.
I share your concern too. I mean, it's really the fact that you're using a lift doesn't mean there's no load there. It's still getting a sling under someone. We've shown is one of the most risky things you can be doing, especially with really heavy people. I'd be really hesitant to implement a lift team.
Thank you.
The other issue with that is if you suddenly say, okay, all of the lifting is done by these 4 people, and you don't train anyone else, there's going to be times when those 4 people aren't there, and then and what happens then, right? And then now you have a less trained workforce.
Am I allowed to ask one more question? Okay. So my other struggle is I work in acute care hospital, and our goal very clearly is to maximize the abilities of individuals so that they can get home. So these are fresh, for instance, post-op knees and hips who have to mobilize because that's why they had the surgery. So I also struggle between equipment, which has its place, and so forth, but also sometimes there is increased risk assumed by staff because of the mandate driven right from the orthopod down to get these moving. Comments?
There are body weight support sling systems, so you can put someone on a ceiling lift with a sling that is just there to make sure they don't fall, right? That they're not lifting them, but you prevent the fall-related having to catch someone if they're falling. And I think it's actually, I think this was something that at the Florida conference, there's a few presentations now on this sort of hidden problem of physiotherapists having back injuries because of this. They're a group that underreports typically because they're supposed to be experts on these things, and it looks really bad if they've injured themselves. So they don't talk about it, but it happens a lot. And so we do need to find safer ways in those instances, I think.
As a physiotherapist myself, I would say that over my career I remember the most difficult conversations that I ever had, and one of those top 10 difficult moments was in front of a group of physiotherapists who challenged me with this, and this was them saying, "These are the tools of my trade, Mike. Don't take this away from me. I feel for flicker and tremor and muscle activity, and I've got incredible skill at promoting balance and activity." And the answer is, and does it hurt? And of course the answer is yes. And Tilak's right. They heal themselves. They go to their own friends and they get treated. They don't go to claims. And they expand. Particularly, orthopedic rehabilitation is one thing, but neurological rehabilitation is a much bigger challenge. And there are, methods by which you can promote sitting to standing just by raising the height of the bed and doing very high sitting to standing and then slightly less high sitting to standing And then there are pieces of equipment that would allow it, and some of it is ceiling track gantry hoist, but there are lots of other ways of promoting mobility where we take away the risk of falling, because it's that full weight bearing activity which is the real hazard. And I think physiotherapy worldwide is moving in that direction, but maybe somewhere slightly slower than others.
We're going to
Good
hear
question.
from our... I'm sorry to cut you off there, Mike. We're going to hear from our group again as we move through the day. I was horrified to see that we have moved through our time, and I was actually just getting into stuff there, so we obviously mistimed this section, but our panel here will be here all day, and you will be hearing from them again, so I invite you to take your questions to them directly, and we'll be hearing from them again. So thank you very much.